Welcomed you to this joint webinar, which we organised jointly with the Health Statistics User Group. And my welcomes on behalf of the RSS. I will then be handing over to Dina Ledbetter, Chair of the Health Statistics User Group, who's going to chair the webinar. Before I do that, on behalf of the section, I really want to thank all the very busy people in the Government Statistical Service who are taking time out to give us their perspective and description of all the massive amount of work they've been doing on COVID-19. I think when your numbers appear in the media, there's not always an appreciation of the huge amount of work that lies behind it. And when people complain that you haven't got it out quick enough, it's not difficult to imagine that the massive task takes a long time, a lot of work, and we know that you've been going over the top to get this done, and rather than spending any more time emphasising the point, I'll just give a thank you, and also to the RSS for hosting the meeting, particularly Luz Martinez, who's put a huge amount of work into this. And having said that, I'll hand over to Dina Ledbetter, who's going to chair the actual webinar.
Okay, thank you, Alison. Can I have the next slide, please, Luz? Or shall I take control? Yes, great. Okay. So this is, so welcome from myself. I'm Dina Ledbetter. I chair Health Stats User Group. I will echo the thanks from Alison for the RSS for actually hosting this, but also these many organisations who participated in putting this together and presenting. I will just sort of note that actually HSC Northern Ireland has actually involved in the first presentation, so we should have had their logo up there as well, so apologies to Northern Ireland for that. So the next slide, please, Luz. Right, just the usual bit of housekeeping before we start. Everyone is muted. The speakers, if they could stay muted when they're not actually speaking, and also if everyone can make sure they turn off their videos when they're not actually speaking. Questions coming in via chat, if you can put question at the start of it, then it helps to identify that from all the general sort of exchange of ideas that sometimes comes out through the chat. All the presentations will be available immediately afterwards. You don't have to worry about that. And also, there is a lot of content in the presentations. So it'll be a challenge for the speakers to kind of cover everything, and also a challenge for us to assimilate it all. So we really see the presentations as something that you can actually look at later. So if they run through quite quickly, don't worry, you'll be able to go back and look at them at your leisure. It is being recorded, and we will put that up on the website for 2 weeks afterwards. Because things change so fast, we only put it up for a short amount of time, and then a report will come together with the Q&A, so you'll be able to see that, and once again can look at that in more detail. So next slide, please, Luz. Before we start, we just wanted to share what we hope is values that we all share, which underpin this webinar and the work we do. Very much the idea that what we are here today to do is to learn from each other and to work in a collaborative way. And that's fostering collaboration, not just between the speakers, but between the speakers and the participants. And once again, not just today in this presentation, but also for any discussions that this prompts, either individually or via the website. So working together and collaborating, we think, is the way forward in this challenging arena. Next slide, please. The speakers, we're covering, first of all, updates. Updates on things that were presented in the 28th of January webinar. So those people who didn't attend that, please go to the website and have a look at some of the background, because today they'll only be presenting an update. The first update from the Four Nations group. Unfortunately, Jennifer Snape is poorly, so not able to present, but Jade and others are available to present. In addition to and Jenny, we also have other members of the Four Nations group here who will maybe assist Jade in the presentation, but also be available for the Q&A. So we do have Alexandra Fitzpatrick and Sean Cross from Welsh Government, and Damien Bennett from HSC Northern Ireland, and also Anthony Myers from the HSC. So there's quite a broad team there who will be able to pick up on some of the questions that will hopefully come out in the Q&A. And then after that is update on the ONS infection survey, and then we move on to introductions to the vaccination statistics. It's still quite early days on vaccination, so the speakers have been asked to give an introduction, and we're hoping that the next webinar in June, July will be able to look in more detail at vaccination statistics. So if we can't cover everything today, this is just a starter, and we'll follow that up with a more detailed webinar later. We'll just run through all of the presentations and then have the Q&A afterwards. And I won't be doing a lot of introduction in before or between them. This is the order in which people are going to speak. So it's really over to the speakers, and we're all looking forward to hearing what you have to say. So first of all, over to Jade and the Four Nations group.
Thank you, Dina.
Thank you. Yeah, I was just about to say Alex is actually going to kick us off.
Yeah, so afternoon, everyone. It is afternoon now. Yeah, just double checking. So as Dina mentioned in her introduction, I'm Alex. I head up the COVID-19 health statistics team in Welsh Government, and my colleague Jade from Public Health Scotland will be presenting alongside me today. And we also have colleagues from Northern Ireland in the room who will be participating in the Q&A section later on. So in the, if you just go to the first slide, please, sorry, or is it being kind of, yeah, perfect, sorry. So in the last RSS event, a few of us from the Four Nations group, sorry, I've lost you all on my screen, there you are, gave some presentations on our different programmes, and we're just going to provide a brief follow-up today to cover the collaboration that takes place between the Four Nations and how our contact tracing statistics differ. So here we're starting with a brief overview of the different contact tracing systems within each of the nations. On this slide, we've just provided kind of an update on the different systems, including information that is published each week, what time period that data covers, and who the key contacts are within each country. We won't go into too much detail for these programmes, as this was covered in the previous presentation and in the previous events sort of Q&A, and we don't want to duplicate for attendees who may have been at that one, but we'll ensure that links to each of our publications are circulated with these slides after the event. And if anyone does happen to have any kind of follow-up questions on specific systems within the countries, then we can address those in our Q&A section, where we'll bring in colleagues from each of the Four Nations. As Dina mentioned, unfortunately, Jenny from DHSC is unable to attend today, so any questions specifically on the England system will need to be sent on to her to respond at a later date. I think you go to the next slide, please. Yeah, so Jade's going to cover some of the kind of differences in our data systems, and then I'll jump back in for the end of the presentation.
Thanks, Alex. So we just wanted to highlight that we do have a Four Nations group, because I think that was a suggestion on the back of the presentations that we did last week, and we meet on a fortnightly basis, and it's almost like a place where we go and discuss similarities and differences, and eventually we hope that we can come out of this group with a document or a publication that actually shows the similarities and differences, but we still feel like we're constantly chasing our tail as things are changing all the time. So we just keep each other up to date and really support each other. So some of the similarities in the programs that we've found is that methods of reaching contact tracing. So at the beginning, we were all using phone calls. Each positive case was being called, and text-based contacts were being traced, and they were being called up as well. And as we subsequently moved and peaks and troughs arrived, then other methods were introduced, which started to bring in some differences. Frequency of publications, we all release a weekly publication that's across the Four Nations. Some of the overall metrics are very similar, the number of cases, the number of contacts that were reached and how long it was taken. And the data feeds, we are all using NHS Digital to certainly collect our testing data, but as time goes on, things like that change. Next slide. So this is probably where we get into the bulk of the differences. So some programs exclude certain types of cases from statistics. Northern Ireland excludes cases without contact details. Wales excludes non-eligible cases. In Scotland, we include everything. I think in other nations, they separate them into complex and non-complex cases, where in Scotland, we don't do that. So there are very wide differences on why you cannot compare like for like, even at the base of number of contacts and number of cases. How cases and contacts are recording. There are now, as I mentioned in the previous slide, there are many different ways. England have a system where a link is sent out to a positive case and they start entering into a website. In Scotland, we started to introduce that at the height, certainly in December and January. Text messages were being sent out to contacts and even cases due to the volume that were coming through. But that was different at different times for different nations. The metrics, very different metrics around what point you start measuring when has a contact trace situation started, and whether it's at the point of when the person is taking a test. The 4 nations aren't always in the agreement of at the point when is the test. Is it a positive test? Is it when they get the positive result? Is it when they get take their test, order their test, because that's potentially when their symptoms started. Very different across the 4 nations. There are some similarities, but they do bring in differences. And whether the outcomes for the case or the contact, they are slightly different meanings across the four nations, and whether it's complete, active, there's different terminologies used across the 4 nations. Next slide. So why data can't be compared is for the many reasons that I've just went into. So we started pulling together a document, and almost the caveats were longer than the actual report. So we felt we had to go back to the drawing board and maybe actually release a publication on why things can't be compared, rather than trying to actually compare but include all the caveats. So these are the things that we've started looking into on what can't be compared, and hopefully in some point in the future we'll actually be able to release something into the public domain that really shows that we have worked together to see and to try and make it easier for the public to understand what the differences are. Next slide. Back to Alex.
Back to me. Thank you, Jade. So yeah, Jade sort of covered this briefly at the beginning. So we just wanted to finish off this presentation with a mention kind of more specifically on our 4 nations contact tracing stats group, as it was kind of highlighted at the last event and asked if this is something that happens. So yeah, we talked earlier about the collaboration that takes place between the 4 nations. Jade mentioned we meet on a fortnightly basis on a Thursday afternoon, which, you know, just once we've survived yet another week of publications, we just like to talk about them even more. And we share sort of upcoming plans within that meeting and any best practice. And we also use the group as an opportunity to discuss sort of future plans where it may be possible to align certain pieces of work. As well as best practice, we also share issues that we have faced when we've been conducting certain piece of analysis, and like problems that we feel may also be or become an issue for the other countries. And we sort of discuss the different resolutions that we've been implementing or that we have implemented to address some of these. I think before we just finish and move on to Q&A, I kind of wanted to say one final thing, and that kind of last bullet here kind of sums it up quite neatly, I think. Like, members share learning and give each other support and advice. As you can probably all imagine, with the administrative nature of most of the data sets we use and the tight turnaround for analysis and publications, that knowledge sharing is incredibly helpful. And in regards to the support and advice, sometimes it's just nice to know that it's not just you experiencing specific issues and like having certain kind of problems with data analysis, and having someone there who's in the same situation as you, sort of to chat these things through and potentially identify opportunities to resolve these, is like super, super helpful. So yeah, I'll leave it there just to provide some time for questions. And I'll speak for myself and my colleagues in the other countries as well, and say that if there's anything that anyone wishes to discuss sort of outside of this event, we're also happy to pick those up and help where we can.
Great, thank you very much. So what we're going to do is we're going to move straight on to the next presentation. We do all the Q&A at the end, gives people a lot of time to put their questions in the chat, and sometimes people can respond in the chat as well as we're going through. So thank you very much, and we'll move straight on to the next presentation, which is also an update from Russell on the COVID-19 infection survey. So over to you, Russell.
Hi, so this is just a brief update since the previous session on results from the COVID-19 infection survey. An update on what the COVID-19 infection survey is. It's a household survey covering all 4 countries that is run out of the ONS, giving regular updates on this is the percentage of the community population who are testing positive for COVID and more. Next slide, please. Here are our latest numbers. As I'm sure everyone is aware, it's been reasonably well, good and boringly flat in most places, which is just excellent. Next slide, please. Compared to where we were before. Next slide, please. In terms of the statistics we put out, we are putting out a few more now. There have been some new developments. One of the things that we put out now that's new is that's not quite new, it's recommenced, is incidence estimates. So the main headline graphs are on any particular day, what is the percentage of the population who test positive in a PCR test in the community. The incidence estimates here are slightly different. This is the estimated number of people per day who are catching the disease, the number of new infections per day. So these are the numbers that are comparable to the test and trace dashboard numbers, loosely comparable, because this is still only referring to the community population representative from our sample. So only in the sense that it's the same basis. The coverage of the two is still different. And it's a very boring time to have introduced this. We introduced this for the blue dots in the chart, and the back dots are the gold coloured ones. Not at all a surprise of this is when the infection must have taken place to match the prevalence estimates that we have, but these estimates are now in the public domain. Next slide, please. The other thing to note is we are updating reasonably regularly the symptomatic and asymptomatic proportions from our sample. Next slide, please. Or even the symptoms themselves. So you can see these are changing slightly over time. For most of the symptoms, we have more people who are symptomatic over Christmas. Next slide, please. Finally, we are now also regularly updating with antibodies and vaccines. The vaccines are our sample modelled on a comparable basis to the prevalence and the antibodies, so that you're able to compare. And the antibodies is based on the blood tests that are being done of the people in our sample. What are the numbers? And you can see, of course, that these are both all shooting up together over the last few months. Next slide, please. This is a separate graph. This is showing antibodies by age group. And you can see, I've taken this from our website. You can click through on the website and it looks kind of cool. You can see already at the end of January there, we've got a big uptick in antibodies for the oldest age groups. where the vaccine campaign has started, and you can track the vaccine campaign over time as it happens in the antibody data that we get from blood draws. Next slide, please. A month later, and you can see exactly how many people now have been additionally vaccinated. Next slide, please. A month later still, and the vaccination campaign is still rolling out. So across each age group, even more people are vaccinated. And in fact, now that we're 2 months after the 85-year-olds getting vaccinated the first time round, you can see that actually it does start to draw down a bit from the blood draws themselves. So you'll see this sort of wave roll down the different age groups as the vaccination campaigns progress in each country. And that should be the end of the brief tour of updates from the ONS survey.
That's great. Thanks very much, Russell. Obviously, you know, a lot in there. And as I said at the beginning, people can then look at these slides later and also follow them on the website. One thing is that we're planning to actually do a sort of summary list of all the very, very useful links to the material that underpins some of these presentations. So you've got a way of actually looking at them and discussing them and thinking about them afterwards. So that was a great overview, and obviously more to think about afterwards for everybody. So we now move on to the sort of second part of the webinar, which is the introduction to the vaccination statistics. And we start with the presentation from Public Health Scotland, which is a two-hander from Diane Stockton and Chris Robertson. So over to you.
This is where we both wait for each other to talk. Anyway, I'm Chris Robertson, so I'll talk most of the time here about this work. So what I'm going to cover is looking at national data in Scotland to work out the effectiveness of the first dose of the vaccine and through the vaccination programme. That's carried out via a study known as EVE, which was set up March 2020 to study the pandemic and early vaccine effectiveness estimates there. And the work's carried out within Public Health Scotland, but with academic researchers. So can I have the next slide, please? So I'm going to cover something about vaccinations, hospitalisations, and looking at vaccine effect, because it's phenomenally tricky to try and establish a vaccine effect separate from a vaccine programme effect using observational data. And I've got 3 study designs: a cohort, a case control study matched at the time people were positive before hospitalisation, and then a target trial approach, which is similar to the Israeli study on vaccine effectiveness, matched at the time of vaccination. So the next slide, please. So this gives the data. It's actually quite up to the end of February when we carried out this analysis, and it shows the age groups that were vaccinated and where the AstraZeneca and the Pfizer vaccine were used. So the orange is the AstraZeneca and PB, the green colour, is the Pfizer vaccine. And you see that the AstraZeneca vaccine, the same as in all over the UK, was predominantly delivered to people over 65 there. So next slide, please. So we're looking at the vaccination impact on hospitalisations. On the graph on the right has got the rate of hospitalisations per 100,000 in the age group, and on the right it's got the number. And there's a lot of interesting things in this. This is daily data with smoothed generalised additive model trends in there. The vertical dotted lines refer to when vaccination was introduced, which actually coincided with an easing of lockdown restrictions in Scotland. And the other 2 dotted lines refer to when the lockdowns were imposed because of the increasing number of cases. So what you can see here is that over the period in Scotland, there's been a huge change in who's been admitted to hospital. It's seen most easily in the graph on the right, where you now see that numbers of people in hospital who are aged over 80 and 65 to 79 have declined to relatively low numbers, about 20 a day, whereas the 18 to 64s, although they've declined, they're levelling off at about 37 per day there. So quite a big change in the distribution of people who are in hospital, and that's consistent with vaccination, but it's also consistent with other things about the transmission of the virus in Scotland. So next slide, please. So this one looks at the uptake in vaccination and the downturn in hospitalisations on the same scale. And this shows you the difficulty in working out vaccine effects from these observational data, because it's quite clear that the downturn in the admissions to hospital, which took place early in January, they cannot be attributed to vaccination, because the numbers that were vaccinated at that time were too small. So the only, you get to about the end of January when 50% of the over 80s in Scotland were vaccinated, and the only inkling that you can see of vaccination impact is that if you look at the trend in the 18 to 64 group post the early January, that trend down is slower than it is in the 80 plus year age group. And furthermore, if you do other change point modelling, which we had done, you've got an accelerating decrease in the over 80s. So that sets the scene for the next slide, please, which shows the background to the cohort method. So this is using about 5.4 million people, only 4.4 over 18. And there's so about 1 million people were vaccinated at the time of this analysis, which was in mid-February. And we're looking at hospitalisations. And the cohort method, the main thing to adjust for is calendar time, because of the changing pattern in the dynamics of the infection in the background population over that period, and lots of other socioeconomic and comorbid condition factors. So there's about maybe 20 of them were in the model as well. So I used Cox models and Poisson regression models, and propensity to get vaccinated was used as well to try and effectively, or try and adjust for the healthy vaccinee effect, where people who are too ill don't get vaccinated, and so the vaccine appears to be much better than it actually is. So next slide, please. So this shows you the main results that we have, showing round about a 70% vaccine effect, corresponding to a hazard ratio of about 0.3 there. It's quite variable towards the end, 42 days after the first dose of the vaccination, because there aren't really terribly many events. You can see in the table that most of the hospitalisation events take place amongst those people who are unvaccinated, but that's largely because most of the population is unvaccinated at the time of doing this analysis. But what this demonstrates is that the vaccination programme does have some impact, and it's about the order of 70% for the vaccine effect, although at 28 days it was actually much higher than that. Next slide, please. So this was just focusing on the people aged over 80, because I want to compare the results in a number of different studies. So again, you see the over 80s, which was the main impact for hospitalisation, as their rates of hospitalisation were much higher. And what you've got here is again evidence of about at least about a 30% hazard ratio of 0.3, so a 70% vaccine effect. The next slide, please. So this was just because we were looking at statistical methods. I have another way of doing the analysis through a nested case control study. And what this is trying to do is to take into account the time effect, because cases were matched to 10 controls at the date of the positive test, which led to hospitalisation. So the cases were hospitalised, the controls were not in hospital for coronavirus at that time, though could have been hospitalised later on. And then we look back to see what their vaccination record at that time So this case control method matches on time, whereas the cohort study adjusted for calendar time, again with the same adjustment for deprivation and comorbidities. So the next slide, please. And this just looks at the figures for the over 80s. You'll see the numbers are actually the same as the previous slides. And again, you see up here at 28 days, it's really rather a very low vaccine, a very low hazard, or this here it's risk ratios in this case, although it's labelled wrongly in the graph. So again, it's in this case a 90% vaccine effect from this nested case control study using the same data. So the next slide, please. This time was to go to another method to try and more replicate the idea of a clinical trial by matching people at the time of vaccination. So what happens in this study design is that individuals who are vaccinated are matched up with a person who's not vaccinated at the time. The matching was done on gender, age, number of comorbid conditions and local area, on exact matching. And if it turned out that the unvaccinated control was vaccinated later on, then both parts of the pair were censored. And this was followed up. Individuals who were vaccinated up to the 14th February were included in this analysis. And it's the same type of analysis through Cox regression, again with adjustment for comorbid conditions. The next slide, please. So this one just shows you the numbers, and what's instructive about this is that there are only 790 hospitalizations used in this matching analysis, whereas the previous cohort and case control studies used the full 8,000 people who had been hospitalised in Scotland since the 8th of December. So with this matching to achieve a balance, you end up losing a lot of cases. We're only using about 10% of them. And you see that down at 43 days, there's hardly any events left in the analysis there. So next slide, please. And this just gives you, in this case, the rate ratios from the matched analysis. And you see that in all ages after 28 days, it's about 65%. And for the 80-year-olds at the same time, it's about 40% vaccine effect, a rate ratio of 0.57. So the next slide, please. And this is just to summarise the three methods for doing it. They're all trying to address different biases, but none of them actually overcome the healthy vaccinee effect. Okay, I think that's all I need to say.
Thanks. Just before Chris finishes, Chris and I thought it'd be really useful to cover the vaccine effectiveness today, but obviously we've got a lot of analysis that we've done around coverage, vaccine failure and vaccine safety as well. So happy to answer questions on those in the Q&A if people are interested in that.
That's great. Thank you very much. Obviously, yes, we can pick up things in the Q&A, and also, as I say, we're hoping that there'll be a follow-up webinar where we can actually discuss some of these things in a little bit more detail when there's more information and we've gone further on in the vaccination programme. So thank you to Scotland, and we now move on to the situation in terms of vaccination statistics for England. So we start with speakers from Public Health England, Colin and Camille. So over to you.
Hi, good afternoon. I think in future webinars, there'll be plenty of opportunities to actually present some data on the vaccine coverage. And what I wanted to do in this session, which is quite short, but is to take a little step back and to think about the question of what really vaccine coverage means. And I think, like a lot of life, it's a little more complicated than it seems at first. Next slide, please. So this is just a quote from a paper and on a monograph done by Eurosurveillance in 2012, which has a series of articles which are and may well be of interest, talking about vaccine coverage and, and national vaccine registers. But we really want to measure vaccine coverage because it's essential in evaluating the success of a vaccination program. So we need to identify susceptible populations for interventions. We need to inform future policy. And of course, all these depend on having an accurate estimate of the eligible population, i.e. the denominator, and a robust method of ascertaining the number of eligible individuals who's received a particular dose. Numerator. Next slide, please. So in the Eurosurveillance monograph, they talk quite a lot about national vaccine registers, and presciently after the 29 pandemic, swine flu, there was a broad recognition that we needed an accurate, rapid information vaccine coverage in a target group, and that these data would be best available within national vaccine registers in a confidential, population-based and computerized manner, which can help strengthen all immunization programs. Next slide, please. So the key attributes of these national vaccine registers are that they should obviously be accurate, be able to provide accurate, up-to-date data, individual level demographic data in the population of interest, as having individual level data is key in calculating accurate coverage. And this should be at an individual level where possible. So these allow us to monitor vaccine uptake at all levels, so from a national through to local level. We can identify unvaccinated subpopulations and optimize vaccine uptake, use the register to direct efforts to increase uptake where it's lacking, and also to link vaccine registers to disease registers and identify specific health outcomes. So we've just heard about the vaccine effectiveness and safety work. And of course, this is dependent on the data that is available in national vaccine registers to a great extent. Next slide, please. We're fortunate in having such a system available. So in England, it is NIMS, Wales, Northern Ireland are developing their own systems. Wales have a well-established one, and Scotland too. But quite apart from the national vaccine registers, which are NIMS is new and computerized and covers the whole of England, we do actually have a long history of vaccine reporting using vaccine registers construed differently in England. Next slide, please. And this is just a shot of a paper published in 1989, looking at coverage of vaccine evaluated rapidly in England. I think the point I'd like to make here is that when the cover program was devised, the R stands for rapidly. Now, way back when, rapidly meant quarterly data. And I think the world has changed quite a lot. And in this pandemic, of course, there's enormous pressure to publish data very rapidly. And so the ability to have data fresh and new, available every week is quite an achievement for everyone involved. But it also brings with it risks in interpretation. And so we've got data that is coming out dynamically as the program is rolled out in slightly differently in different areas, and all of that needs to be borne into account when we're interpreting the data. Next slide, please. So in order to talk about this in a little more detail and think about how we might measure vaccine coverage or uptake, I'm going to present slightly silly scenarios, but I think they'll illustrate the point. So in this hypothetical scenario, we have a population of 2 million. Now we can measure the population, say, in two different ways. And we have method A, which is an estimated population based on census data. So this is a bucket of an estimated number of people. Method B is a registered population. So this is a line list of real people as we might have in a vaccine register. Or people with an NHS number, registered with a local GP, etc., however it might be constructed. So we have two different denominator populations, but method B, because it's a dynamic registered population, allows it to be measured at any point in time at the point we want to measure coverage. and takes into account movements in and out of the population, either geographical, births, deaths, etc. Next slide, please. So our vaccination program starts, and after 3 months, we have vaccinated 1 million people. What's the coverage? Well, it's obvious, isn't it? We've vaccinated 1 million people. This is the numerator divided by the denominator from either population source A or B, which both give us 2 million people and gives us a coverage of 50%. Furthermore, it doesn't look like there's any particular advantage to using a denominator from either source. They both seem to be providing the same number, same size of denominator. So what's the problem? But actually, we do have further information available and affects how we might manage the numerator and denominator at the time we want to measure coverage. Next slide, please. So I have 3 slightly silly scenarios. So in the first scenario, after our vaccination program has started, we vaccinated 1 million people of the 2 million, but 50% of the population have been abducted by aliens, and none of those who were abducted received the vaccine. What's the coverage? Well, if we use population A, which is, say, a static population, we can calculate it as 50. So we've had 1 million vaccinated. We have no information about who has been abducted. Our denominator is 2 million, so we have 50%. But if we have a dynamic register using population B, so we know that everyone who has received a vaccine, sorry, no one who's received a vaccine has been abducted. Therefore, we have 1 million people alive and vaccinated, over 1 million people left in the population. So our coverage is actually 100% calculated this way. Next slide, please. In the second scenario, slightly the opposite of the first one, where everyone who is abducted has received the vaccine. So if we run through the calculations again, in the first method, we might say it's 50% because we're not taking into account the movements in the population, but using population B, taking into account that everyone who's been vaccinated has been abducted by aliens, we end up with a situation where no one who is alive and registered has been vaccinated, and therefore our coverage is 0. Scenario 3 coming up. And the last scenario, what we're going to do is just equally distribute the abductees between the vaccinated and unvaccinated population. And if we go through, we can use population A perhaps in 2 ways. In the first scenario where we have no information about abductions, and again, it's 50%. If we have information about the abductions in the numerator, but we're not taking into account in the denominator, we end up with a coverage of 25%. And again, using population B, where we're taking into account the abductions in both the numerator and the denominator in the same way, we get a coverage of 50%. So although these scenarios are slightly silly, I think they illustrate the point. The next slide, please. That we have actually different questions. And what we need to understand is the question we're trying to ask before we can work out how we're going to calculate it and how we're going to present the answer. Next slide, please. So the question 1 might be, how many people have we vaccinated in total? So this could be an operational question. And we need to know the number of people vaccinated, whether or not they have moved, migrated, or died. So this might be a target. So if we might have a target of vaccinating 2 million people, and at the end of a specified period, we vaccinated 1 million, then we have met 50% of the targeted population. And that is fine. We also might need to know the question, what is coverage at point T in the program? So this is more a public health question. We need to understand what proportion of the population at the time we're measuring it are susceptible to the disease and therefore need to be reached for vaccination. So we can use a dynamic numerator and denominator, making sure that people who move in and out of the population are accounted for, so we know how many people are unvaccinated, susceptible, and need to be reached. And then, of course, there are third questions about safety and effectiveness, and it needs to understand, for example, who has died. We need to understand, correctly account for people who have died and moved in both the numerators and the denominators in a different way to that is calculated, is taken into account in the other 2 questions. Next slide, please. So, of course, it's a very straightforward definition that we have used, and you will see that when we talk about coverage and uptake, the terms are quite often used interchangeably. There are technicalities we could go into, but reality is a bit more complicated than that. And the cover user guide, which I've linked to here in the slide, does have some further definitions of the routine vaccinations in the program, which of course are different to that and depend on time periods, etc. So it's a bit more complicated than that. But if we move on to the next slide, I've just provided some links here to the current data on the vaccine uptake for England. And next slide. I would like to thank you all for listening.
Thank you very much. That was a very useful introduction, and obviously we look forward in the next webinar to the more detailed figures, but also those links were really great so that people can actually look at the information that is available. So we now move on to the final presentation, which is looking at a specific aspect of this, which is Vahe talking about vaccination rates by socio-demographic characteristics. So over to you, Vahe.
Hello, everybody. So I'm going to present the work we've published on the ONS website on the 29th of March, looking at the vaccination, the rates of people having received the first dose of a vaccination, of a COVID-19 vaccination, broken down by social demographic characteristics. It's probably not going to be as fun as the alien examples, unfortunately, but please bear with me. So next slide, please. So just a bit of background about our study population and how we derive the data set. So what we use the data from the ONS public health data asset, which is a unique linked data set that combines the 2011 census, the General Practice Extraction Service data for pandemic planning and research, more commonly known as GPAS, to the hospital statistics and mortality registration data. And in this particular publication, we focused on adults aged 70 or over. And we linked the public health data asset to the NIMS data using the NHS number. And we achieved a linkage rate of 94%. So one of the reasons why people could be in NIMS but not in the ONS public health data is because our study population only include people who were enumerated at the time, enumerated at the 2011 census. And the coverage rate of the census is about 94%. The other source of discrepancy could be that some people took part of the census, but we couldn't link them to the patient register, so that we didn't manage to have an NHS number for them. So we've got a few people who are not vaccinated. So we did a bit of analysis on looking at the population, like the different characteristics of vaccinated and unvaccinated. You can see the average age is the same, but we've got a bit more. We've got more women, a higher proportion of women in our linked data than in the unlinked data. Next slide, please. So that having this data set, we could leverage all the data from the 2011 census and to look at different characteristics. So that are traditionally not recorded in the electronic health records, or not as well as in the census, such as ethnicity. And we could also do some regression analysis to try to look into the differences in vaccination in a bit more detail. So what we did, we focused on 4 main characteristics in our report, which was ethnicity, religion, disability, and area deprivation. And we also so we looked at rates and then some odds ratios. So on the left, you've got the vaccination rates of adult age 70 over by self-reported ethnic groups. So we had an overall. So it's worth saying that we had an overall vaccination rate of about 90% as of the 11th of March, and that is slightly lower than what we would have in the official figures. So there's a few reasons for the discrepancy. First is our study population isn't the same. Second is that our data feed may be lagging for a few days behind. We have incomplete data up to probably until the 11th of March. So the main message is not about the actual level, but more about the relative differences. And we do find wide variation. So if you look at ethnic groups, so all ethnic minority groups had a lower vaccination rate than the white British, and the lowest vaccination rate was observed among people identifying as Black African or Black Caribbean, with a vaccination rate of 58.8% and 68.7% respectively. And we also found a low rate of vaccination in people from Bangladeshi or Pakistani background as well. So then what we went on doing is trying to explain a bit the differences. So are these differences basically driven by differences in geography, where people live, or differences in age, or in whether they live in care home, or in the socioeconomic status, or in the health outcomes? So we built some models, including a wide range of socio-demographic characteristics, and also comorbidities that are relevant for COVID-19. So for comorbidities, we used all the comorbidities defined as in the Q-COVID risk prediction model. And we modeled the odds ratios of not having received a first dose of a vaccination for COVID-19, with the white British group being the reference group. And here what we show is the unadjusted odds ratios. They will tell you like the actual difference. So you can compute these based on the right and the left, and then the fully adjusted one. And what is interesting is to look at to look at the change in odds ratios between the unadjusted and the fully adjusted model, because it tells you it tells you what proportion of the difference is due to the factors that we adjust for. And what we find here is that once we adjust for the other mediators, we do find it does reduce the estimated differences to an extent, but not by much. So for instance, for Black African, the unadjusted odds ratios are 7.4, and you move to 5.5 once we adjust for these factors. And this indicates that the factors included in the model only explain about 30% of the differences in the odds of not being vaccinated. So it means that there is something that is specific to ethnic groups that is not due to just deprivation or other factors. So that has some interesting relevant policy implications, suggesting that the vaccination should probably be targeted at this group. Next slide, please. So we conducted the same analysis for religious affiliation. So we could find differences in vaccination rate by religious affiliation. So with Christian having the highest vaccination rates, and reduced lower vaccination rates in several religious groups, such as Buddhist and Muslim. And again, when we did some models, so it didn't other factors didn't explain all of the differences between groups. So for some religion, it did. I think for some religious groups, such as Jewish or the Sikh, once we adjusted for other factors, that we observed no differences. So that it probably means that the differences compared to Christian for these groups were fully driven by social demographic factors and also prior health, pre-pandemic health status. Next slide, please. We also looked at area deprivation. So here, area deprivation was based from the 2019 postcode, and we do find a clear gradient in vaccination rates between the most people living in the most deprived area and people living in the least deprived areas. But something to note is that the difference is not as pronounced or marked as by ethnic groups. So it goes from about 92% for the least deprived area to 87% for the most deprived area. So still notable differences, but it's not as large as for other factors. And here we show that if we adjust for factors including ethnicity, again, we can still observe a strong gradient. Next slide, please. So we also looked at disability. So here it's a big caveat on this analysis because it's disability status at the time of the census, which is likely to have changed significantly. So we'll have lots of misclassification error here. But we do find some differences between people who are non-disabled people and people who are disabled and report being limited a little or limited a lot in their day-to-day activity. And again, we found that if we adjust for important confounding factors here, such as actually like comorbidities from clinical records, we still observe an elevated risk of not being vaccinated amongst people who have not were disabled, especially people who are limited a lot. Okay, next slide. Ah, perfect. It's been done then.
Thank you very much, Vahe, and thank you to all the presenters. Obviously, quite a wide range of different things to consider, and obviously lots of questions coming in through the chat. So at this point, we finished with the presentations and we hand over to the Q&A. So I hand over to my colleague, Munira Ahmed, who's been looking through the chats as they've come in, and we'll be trying to sort of summarize and read out the questions and then asking the presenters to comment or respond. It probably will be good if we actually ask the presenters to put on their videos when they're responding, so people know who's actually talking to them. So if you're willing to put on your cameras for the presenters, that would be great. So over to you, Munira, in terms of for the Q&A.
Oh, thank you very much, Dina, and thank you to all the presenters as well as all those that have attended and have been keeping me busy over the last hour in the chat. So thank you, I sincerely do thank you for that. So the question has been quite a good way of trying to get more of the information on, because what I've seen is some of the speakers have responded to the chat. I do appreciate some people on the call might be joining from different devices, so you might actually not get to see the chat. So my intention is to kind of go through some of the questions that came up and invite some of the speakers to come in and just share the responses they've given. And there are some questions that haven't been asked, so I'll make sure I can bring them in too. Okay. So I'm going to do this in two parts. So if we can go with the test, trace and protect, and then I'll bring in the vaccination speakers. So, and I know Alexandra's left, but Jade, I think you're still there from a Phonations perspective, and Russell, you're still there as well?
Yes.
Oh, great. And Jade, are you still there?
I think Jade had to leave. I'm still here, James, in Northern Ireland, yeah.
Yeah, not sorry. Okay, so I'll read out some of the questions. Some of the responses that came through, but others I'll just open up to the speakers around the test and protect who respond to that. So we had questions raised, and thank you very much from Jonathan, Deborah, and Andy that raised questions around this area. So why do Wales and England and Scotland not all have different methods? And that was very helpfully responded around, because there are different government and policy people that are making these decisions. One of the questions raised was about, from Deborah, thank you, how do you plan to perform data integration in order to present UK-wide results? And there's been a helpful response being put into that around some concentrated effort and using the different levels of published data. And once they have been finalised, these will be compared from a raw data perspective and see what can be collected. And again, the more detailed updates, we will, as Dina said, we will share this at the end of the webinar as well, and make these available online. I do have a question that Deborah raised that I don't think has been answered, so we welcome responses from the test, trace and protect speakers. Will the data ever be available for academic research purposes in any way? So maybe, Russell, if I can come to you, or others are able to respond on behalf of the Phonations.
So actually what we've got is we've got actually some of the Phonations group. Damien is still here, and I think Anthony as well. So there are members of the Phonations group in addition to even if the presenters have left. So it would be over to them as well.
Great. Yeah. So that question, will the data be available for academic and research purposes?
Yeah, I think the short answer to that is I don't know. There was quite a detailed DPIAs which have been gone through from a trace perspective, because it's easy enough to set things up for infectious disease in terms of cases. It's a lot more difficult to collect data on contacts of people, and because you're collecting data just for purposes of contact tracing. So if you're sharing data for non-cases from the contact tracing perspective, I imagine from our side anyway, considering the DPIAs who had side of might be a little bit problematic in anonymization. Well, would you just on some of the other questions, what might help people, because they might be a bit flummoxed by how different our data is. A lot of it is because the systems have been set up so differently. So, for example, contact tracing in Northern Ireland is undertaken by the Public Health Agency, the equivalent of Public Health England, and we have actually employed staff directly to do that contact tracing. And what usually happens is common exposures are identified, for example, bars and restaurants people might have attended. We would then be the same organisation who would follow up on those clusters and outbreaks and so on. So it's the one organisation. So in contact tracing, we would do a lot more than, for example, the contact tracing service out, and their function is just to make the calls and collect the information. So Public Health then would analyse and produce common exposure reports, and then outbreaks will be followed up by relevant health protection units. So as a result, the actual data systems which have been set up and what's being collected is quite different. And for example, just to give a simple example, how we consider a successful or unsuccessful call to a case or a contact is something a little bit different, and the terminology is actually reached or not reached, because some people are now using text messages to contacts, and that's considered to be a successful completion of that particular event. So that's just giving you a brief, I suppose, overview of maybe some of the reasons why the data isn't as simple as it might seem. And we would say that even from a simple metrics perspective, it's very difficult to actually have agreement on, for example, what a successful call is within 24 to 48 hours, because they're some of the key time frames in which we're trying to reach people.
Great, thank you very much, Damien. Damien, you were cutting out for me a little bit. Hopefully others will be able to have heard that response, but we'll probably come back to you and get a bit of a written response, and we'll add that to the Q&A as well. But thank you very much for taking us through that.
Sorry about that, I'm sorry.
No, that's okay. Bandwidth, we're all contending with it, living in our home lives right now. Russell, I was wondering if you had anything from your perspective you wanted to add to that?
Yes, the ONS data will be available and is currently available for academic use through the standard channels.
Great, thank you very much, Russell. Russell, and there's another question really raised by Jonathan, and he was asking from your presentation, are the people statisticians, and what level of understanding of data versus the total confusion that this is causing? Therefore, is the data trusted? What rules are being applied? So I was wondering if you had any thoughts. There's quite a few bits in there, but anything else to add on to that?
Sorry, Colin's question. Let me find it.
No, Jonathan. Jonathan.
Yes. Sorry, I didn't see that first time. Are you sure this is a question for ONS rather than the contact tracing of people following the rules?
Any thoughts on that, Russell?
So I believe that there has been a separate survey done jointly between ONS and Department for Health and Social Care on compliance with test and trace. I believe that was in England. You'll have to look on the ONS website for more details. Or the media. I think it was reported at the time.
Okay. Thank you very much for that, Russell. Okay, thank you very much for the presenters coming on, with the cameras on, and sharing some of that. I'm going to move on to vaccinations. So if I could kindly ask for Chris, Diane, Colin and Vahi to put their cameras on, if that's okay. And I'm going to run through some of the questions, and I see, Chris, you've bet me to some of it because you've already responded to some of that in the chat. So thank you very much for that. But for those that can't see the chat, I'm going to just repeat some of these questions and allow yourself to respond to that. So I'll answer the first couple too, and Chris, you responded to one of them anyhow. So this was from Svetlana Nils. Is there data for vaccinations for people who recovered from COVID? And also, Chris, you may just want to share what you've added in about, were you able to glean any insight into the relative performance of AZ and PB? I know you've responded to that, but it'd be nice just to hear you say that out loud for those that can't see the chat. Thank you.
Yeah, there are data on vaccinations among people who have previously had coronavirus. We haven't actually looked at it yet because of other conflicting priorities, but it's certainly feasible to do it for those that tested positive. And also because within this study, we're able to link in all the serology samples in Scotland, we'll be able to do it for the relatively few. I mean, there's only probably about 10 to 15,000 serology samples that we can look at for vaccination post-positive serology. So yeah, we can do that, but I think it's not something that's going to come out of Scotland alone, and we'd probably need to pool data from the 4 countries in the UK to do something. And for the question about comparing the vaccines, we didn't even try to do it. We presented stuff separately because they're given to separate people, to different subgroups of the population. So you can't directly look at them. Both vaccines appear to work pretty well, but it would need a special study design to try and, with this observational cohort, to try and effectively replicate a randomized trial where you're giving Pfizer to one and AstraZeneca to the other. And that target trial approach might be amongst people who are in their 65 to 75 to 80 age group, that age group where they were largely, both vaccines were available at the same time and they were both given in early January. We might be able to do the target trial approach in that case, but there is a big proviso in Scotland. The Pfizer vaccine given to the 65 to 80-year-old were given in the large vaccination centres, whereas the AstraZeneca one was distributed through GPs. And there may be some conditions, particularly to do with access and frailty, which means more frail individuals can't go to the vaccine centres, or people with serious comorbidities who don't leave their house wouldn't go to the vaccine centres. So they would get the AstraZeneca vaccine by default. And it's really difficult to adjust and to deal with that type of bias in administrative data.
Okay, well, thank you very much for that, Chris. Diane, is there anything else you'd like to add? See, you posted a link in the chat as well. We'll make sure that is shared after the webinar as well. Great. Okay, I'm going to move on to the next set of questions. Maybe Colin and Vahe, you might have some thoughts around this. We've got questions raised in the ethnicity analysis. The question was, how were the differences in the sample sizes accounted for? And linked to that also is how strongly correlated are the effects of religion and race on vaccine uptake. So Colin, can I come to you and then maybe Vahe, just some thoughts from you as well? Thank you, Colin.
Yeah, I think those are actually questions specifically for the ONS study, so it's probably one for Vahe to answer.
Yes, so thank you very much. So for the sample size, so yeah, obviously the groups have different sizes. We do have the full data set on all the people who are enumerated in the census. So we basically just do an analysis of the data we have. But it's nowhere to say, even if the sample size are relatively small, they remain relatively high in terms of counts. We do have hundreds of thousands of people, so we just computed rates with confidence intervals and sample yield ratios. We didn't do a big amount of work on that. So for the correlation between ethnicity and region, that's a very good point. So basically, when we, to a large extent, you can find that the same groups. So if you look at, for instance, Muslims and people from Bangladeshi and Pakistani background, they do overlap a lot. So there is a huge correlation between the ethnicity and religion. So in models, we never, when we look at religion, we don't adjust for ethnicity and vice versa, because it wouldn't really make much sense to do so. And you would have lots of categories, if you do a cross tab of ethnicity and religion, you end up with cells that are nearly empty. Not fully empty, so it would probably work from a purely statistical point of view. But I think it would make the interpretation of the coefficients almost impossible, at least in my in the way I see this problem. So so the answer is how do we deal with this? We just look at them separately.
Okay.
Hope this is helpful.
No, thank you very much for that. I'm going to move on to one of the questions that Colin, this was for you, so hopefully I get a chance for you to say. So this was raised by Jonathan Smythe-Renshaw. So he kind of picked up the numbers around the first and the second dosage of vaccine in England. And he'd asked, with lockdown easing in the last of the summer cases, will we have to wait till later in the year to see the real impact of the vaccine?
So obviously a lot of the early vaccine infections and stuff has been looking at dose 1. With it in England, given that dose 2's rolled out 12 weeks after dose 1, there's obviously quite a considerable lag before we can start to look at fully the impact of dose 2 on the vaccine effectiveness side. So, that data will take time, but it is being looked at.
Good. Thank you very much, Colin. So I'm just going to go through. I think most of the questions have been already answered. And I see there's another nice wee link being posted in as well around the impact of COVID vaccine programme. And again, those that aren't able to see the chat, please don't worry. We will make sure we summarise the questions as well as all the additional links that have been shared by the speakers and others as well. So Dina, I'm going to probably hand over to you now. So just thank the vaccine speakers. Hand over to you now. And if any questions do arise, I'll let you know, but just hand over to you for the next part.
Great. Thank you very much, Munira. That's always a challenging bit of these webinars, I think, with all the number of questions that come in. So thank you to all the presenters for their responses, and thank you to everyone for the Q&A. Just as Munira said, we will make sure that the links are put together in a document, and that will be posted on the website, on the Health Stats User Group website. And also we will be giving the speakers an opportunity to respond in writing, because there is a limit to how much you can say in a very short Q&A. And so there will be a report coming out, hopefully within just a week or two, as quickly as possible, but obviously give us a moment to actually pull it together and for the speakers to have a chance to respond in writing. So you will see the presentations up on the website very soon. And then within a next week or so, there will be a report with a Q&A, and also the recording will go up. So if you know people who would have been interested to see this, or you want to actually see it yourself again, then you can point people to the direction of the recording. We'll let everyone know when those things are up, but you can keep an eye on the Health Stats User Group website as well. And if you have any queries or comments, there is that webinar address that we actually gave in the publicity. So please feel free to email us as well. So this is part of an ongoing discussion, an ongoing exchange of ideas and collaboration. There are no fixed and right answers. We are all learning as we go along, and these exchange of ideas and collaboration, I think, is always very, very helpful. So I think that probably brings us more or less to the end of the session, unless there's anybody else in terms of the speakers and organisers who wants to chip in with any final thoughts. I'll just give you, anyone else wants to pick up on anything. And I think that's probably as far as we go for now, but it's not as far as we go, because basically more will come out in terms of the presentations and the Q&A and the report. And just flag up that there are some work being done on the Health Stats User Group website, the Stats Usernet, in the next day, in Friday, so maybe Friday, Saturday. So if there's some issues and things haven't gone up, then come back to us on Monday. We're hoping to get up some of the immediate stuff before the website goes down. It's just a routine maintenance that they're very helpfully put off until after the webinar. But if there's any issues, then wait till Monday and hopefully things will be up then. So I think probably all it leaves for me to say is thank you very much for participating, speakers, organisers, and also the participants for your Q&A. And thank you. And I don't need to say safe journey because everyone's doing it from their homes. So, okay, thank you and goodbye.
Bye-bye. Thank you.